If you walked out of your last appointment holding a blood result that said your kidney function was fine, there is a urine test that may tell a different story entirely. And the reason you probably haven't had it is not because your doctor doesn't care. A team led by Dr. Sanchez Ospina and colleagues published findings in Clinical Kidney Journal in May of 2025. They screened nearly 10,000 adults in primary care, people with real results, real doctors, real routine visits. In the group whose blood work showed a normal filtering score, the urine test identified kidney disease in more than 1 in 10 of them. Blood work, normal. Urine test, a different picture. More than 1 in 10. And that was just the people whose blood looked fine. Among adults who already knew they had kidney disease, adding this one urine test moved more than a third of them into a higher risk category than their blood work alone would have placed them in. You are in one of two situations right now, and there is no way to know which without the test. In the first situation, your blood result is giving you an accurate picture. Your kidneys are filtering at a level that reflects what's actually happening inside them. The urine test, if ordered, would match. You're where you think you are. In the second situation, your blood result is measuring the functional output, how much your kidneys are still producing, while the structural damage, the actual fraying of the filter that drives where your numbers go next, has already begun. It is showing up somewhere your doctor isn't looking, not because they're careless, because the test that would catch it isn't on the panel that was ordered, the filter is fraying, the smoke is already there, and the alarm was never set. By the end of this hour, you will know which of those two situations is more likely yours. You will know the name of the specific urine test, what it measures, what its number means, and what the categories are. You will know the finding that places you on what the current international guideline calls a risk map, a map that cannot be completed without this test. You will know the exact words that get this test ordered at your next appointment. You will know how to ask for the result to be documented in a way that travels with you to every clinician you see from this point forward. And you will understand why the test exists, why it catches damage before your blood work moves, and why the absence of it from your last panel was a gap in the system, not a verdict on your health. Before we go any further, one thing that matters. Do not change any kidney medication based on this video. Do not skip a dose. Do not alter any treatment plan on the strength of what you learn here. What we are doing is learning something specific so that you can walk into your next appointment and have a better, more precise conversation with your kidney team. That is the whole purpose. If you have your last set of kidney labs, the printout or the patient portal result, pull it up now. Find the line that says creatinine or eGFR. If you don't have it in front of you, picture the number your doctor mentioned. Hold it. We'll come back to it. You sat in that chair, the results came up on the screen, or they were handed to you on a printout, or you pulled them up on your phone from a portal notification. Your doctor looked at the creatinine, looked at the eGFR, looked at the electrolytes, said something, it varies, but it probably landed somewhere in the range of that's holding steady, or that's about where we'd expect it, or we'll keep an eye on it, and you nodded because the numbers were there and they weren't alarming, and your doctor seemed satisfied, and you left. And somewhere on the drive home, or that evening, or at 2 in the morning, something came back. Not a specific thought, more of an unresolved question that didn't have words yet, because the result said fine, and yet you're here. Still watching, still looking, still carrying the low-frequency awareness that the number doesn't tell the whole story. You've tried searching. You've read things that scared you and things that reassured you, and neither of those felt entirely accurate. You've maybe cut something out of your diet, or added something, or taken a supplement someone mentioned, and the question underneath all of it, the one you haven't been able to put words to, is this: if the blood test is looking at the right thing, why does something still feel unresolved? By the end of this hour, you will have the words. There are 3 kinds of people watching this right now, and they are all in the right place. The first is someone who received a result recently. A creatinine that came back elevated, or an eGFR that came back lower than expected, or a label like stage 3 that arrived without a clear explanation of what it means or what happens now. You may be on a kidney protective medication, or you may not be yet. You are doing what people do when something has changed and nobody fully explained it. You are searching at night, trying to understand what the number means for your actual life. What you need most right now is not reassurance. It is a precise explanation of what is being measured and what isn't. You will have that by the time this ends. The second is someone who has been managing kidney numbers for a year or more. You track your labs, you go to your appointments, you have adjusted your diet or your medication, or both, and a result came back recently that didn't move the way you expected, or stayed the same when you were hoping it would improve, and what you want is the explanation nobody has offered. The mechanism underneath the numbers that would tell you why what you're doing is or isn't working, and what the next level of precision looks like. You are past the basics. You will get something past the basics here. The third is someone who has been flagged. A result came back, a doctor mentioned kidney function, you felt fine so you didn't pursue it, and then something recent brought you back. A number, a symptom, a conversation. You're not sure how serious this is. You don't feel sick. You're wondering whether the monitoring matters as much as it sounds like it might. The answer to that question is in the biology, and the biology is where we're going. What you need is not a lecture about what you should have done. You need one fact that tells you what the test actually catches and why feeling fine and kidneys are fine are two measurements on entirely different scales. No matter which of those three you are, the mechanism underneath is the same. It starts with something no routine blood panel actually measures, a signal your kidneys are sending through a different channel entirely, one that is almost never picked up unless someone specifically asks for it. Consider someone at exactly this point. Call her Claire Whitmore, 63 years old, managed hypertension for 11 years, sees her primary care physician twice a year and a nephrologist once. Her most recent labs came back with a creatinine of 1.1, within the reference range printed on the report. Her eGFR calculated to 52, placing her in stage 3A, meaning her kidneys are filtering at roughly 52% of the capacity expected in a healthy adult her age. Her doctor noted it, said it was consistent with her prior results, and the visit moved on. Her standard urinalysis dipstick, the routine urine test, the one that gets dipped into a sample and pulled out in a few seconds, came back negative for protein. Her labs across every column looked like they were in range or close to it. A separate test was then ordered specifically for Claire, the urine albumin-to-creatinine ratio, measured on a morning urine sample sent to the laboratory. Her result, 68 milligrams per gram. That number sits in a category the International CKD guideline calls A2, moderately increased albuminuria in a range of 30 to 300. The dipstick, the one that was negative, does not reliably detect protein at this level. It is not built to. It is a screening tool calibrated for much larger leaks. The uACR found what the dipstick didn't, and that number, 68, sitting in category A2, combined with an eGFR of 52, places Claire in a different cell on the risk map than her blood work alone would have put her. To understand why that matters, you need to understand what the uACR is actually measuring and why it catches damage before the eGFR moves. Your kidney filter is a structure called the glomerulus, from the Latin for little ball, which is roughly what it looks like under a microscope. A tiny tangle of specialized capillaries wrapped in a filtering membrane so fine it keeps most large molecules, including proteins, sealed inside your blood. Your blood carries proteins. Albumin is the most abundant one, a transport protein that carries hormones and minerals and keeps fluid balance between your blood and your tissues. In a healthy kidney, the filter's weave is tight enough that albumin stays in the blood almost entirely. A trace amount may cross, which is why A1, under 30 milligrams per gram, is considered normal or mildly elevated rather than zero. The filter is not a wall, but it is tight enough that meaningful amounts of albumin do not cross when the filter is intact. When the filter starts to sustain damage, from sustained high blood pressure, from blood sugar effects on the tiny vessels, from the internal pressure of a kidney working with fewer functioning nephrons, from inflammation, the weave begins to fray. The gaps widen at the molecular level, and albumin, which was previously held back, begins to cross into the urine in measurable amounts. This fraying is structural. It is damage to the architecture of the filter itself, and it happens before the overall filtering rate, the eGFR, drops enough to register as a change in your creatinine or your kidney function score. The filter can be fraying, Albumin can be crossing for months or years before the eGFR has moved enough to change your category or raise a flag on your metabolic panel. This is the smoke alarm distinction. The eGFR is a measure of what your kidneys are still producing, how much filtering output is still happening. It is a functional measurement. It tells you what the result is. The uACR is a measure of structural damage, the state of the filter itself. It tells you what is happening to the infrastructure. Smoke appears before the fire takes hold. The filter frays before the output drops. And the test that catches the fraying, the uACR, is not on the standard metabolic panel. It is not ordered at most routine visits. It has to be specifically requested. The ONDAAS investigators, including Dr. Sanchez Ospina and colleagues, documented this gap in real-world primary care. Published in Clinical Kidney Journal in May 2025, their findings from 9,890 adults demonstrated that in participants whose eGFR was above 60, meaning blood work that would conventionally be read as within normal range for kidney function, uACR screening still identified chronic kidney disease in 10.88% of them, more than 1 in 10. Not because their blood work was wrong, but because their blood work was measuring the output, and the structural damage had not yet reached the output. Among participants already known to have CKD, adding the uACR reclassified 35.57% of them to a higher risk category. Their stage was incomplete without it. Now, the ONDAAS study is observational. It describes what was found in a screened population, rather than testing an intervention. That matters for how we interpret it. It does not tell us what would have happened to these individuals over time, or whether earlier uACR detection and isolation changes outcomes. What it tells us clearly is that the gap is real, it is common, and it is currently operating in primary care in the direction of underdetection. For a viewer in Claire's situation, eGFR in the 50s, blood work that looks stable, no positive dipstick, the ONDAAS finding means that a substantial fraction of people presenting exactly like her are carrying a higher risk picture than their standard panel reveals. For Claire specifically, and Nariao's, and for those in the illustrative situation she represents, the uACR result of 68 milligrams per gram is not a sentence. It is a coordinate. It places her on a map. The map is the KDIGO 2024 Risk Heat Map, the staging system published in the current international guideline for CKD evaluation and management by Dr. Levin and colleagues in Kidney International in 2024. That guideline requires explicitly both an eGFR and a uACR to complete CKD staging. One without the other is an incomplete picture by the standard the guideline sets. Claire's eGFR of 52 places her in the G3 row of the heat map. Her uACR of 68, A2, places her in the column for moderately increased albuminuria. G3A combined with A2 is classified as high risk in the KDIGO framework. Her blood work alone, G3A with an assumed A1 because the dipstick was negative, would have placed her in moderate risk. One column to the left, one cell with a different clinical weight. The guidelines mandate for the uACR is not new. It was part of the original KDIGO-CKD framework introduced in 2012, reinforced in every iteration since. The KDIGO 2024 update specifies annual monitoring of CKD using both eGFR and uACR, and notes that a doubling of the uACR on a subsequent test, above and beyond what laboratory variability alone would predict, warrants clinical evaluation. The uACR is not a supplemental test or an optional add-on in a specialist's toolkit. It is one of the 2 required measurements for staging the condition. Without it, the stage is incomplete. Pull out your last kidney labs now, find the eGFR line, find the creatinine line, then look for a uACR. It may be listed as urine albumin-to-creatinine ratio, ACR, microalbumin-to-creatinine, or albumin-to-creatinine. If you don't see it on the panel, that is not a typo. That is the gap this video is describing. Write down your eGFR. Write down whether you see a uACR result anywhere on that report. Those 2 facts together, present or absent, are where this conversation starts. The question in your head right now is probably how this actually works inside the kidney at the level of the cells and the structures. Why albumin crosses when the filter phrase, what is physically happening, and why it moves before the eGFR does. The answer is a mechanism that standard explanations almost never reach. And once you understand it, you will know not just that the uACR matters, but why it matters, which is the difference between a fact you carry and an understanding you can use. A healthy kidney filter, the glomerulus, is not a simple hole. It is a layered structure. The innermost layer is the capillary endothelium, a single layer of cells lining the blood vessel that has small gaps called fenestrae, windows, that allow water and small solutes to cross. Behind that sits the glomerular basement membrane, a dense mat of proteins, primarily collagen type 4 and laminin, that provides the main size selective barrier. Beyond that is the outermost layer, formed by cells called podocytes, specialized epithelial cells that wrap around the capillaries with long projections called foot processes. Where adjacent foot processes meet, they form narrow slits called slit diaphragms, which are the final gatekeepers of what crosses into the urine. Albumin is a protein about 7 nanometers in diameter. It is also negatively charged. The glomerular basement membrane is also negatively charged. Like charges repel, and which means albumin faces both a size barrier and an electrostatic barrier as it approaches the filter. In a healthy kidney, these two barriers together hold albumin back almost entirely. The tiny amount that does cross is largely reabsorbed in the tubule and returned to circulation. What appears in the urine is a trace, less than 30 milligrams per gram of creatinine. When the filter sustains damage from hypertension-driven pressure on the capillary walls, from glycation of the basement membrane proteins in the setting of blood sugar effects, from inflammatory mediators, from the sustained overwork of hyperfiltration in a kidney with reduced nephron mass, these barriers degrade in specific ways. Hypertension stretches the capillary endothelium, widening the fenestrae. Glycation and oxidative stress alter the charge density of the basement membrane, reducing the electrostatic repulsion against albumin. Inflammation disrupts the podocyte foot processes and the slit diaphragms, the final barrier, through a process of podocyte injury and effacement. Each of these mechanisms allows more albumin to cross into the filtrate, and each of these mechanisms occurs at the structural level, at the level of the filter's architecture, before the filter has lost enough total functioning mass to register as a significant drop in the eGFR. This is the critical sequence, and it is worth stating plainly. Structural damage precedes functional loss. The filter phrase before the output drops. Albumin crosses before the eGFR falls. And this sequence is not incidental. Albuminuria is not merely a signal that damage has occurred. The protein that crosses the filter does additional harm as it moves through the tubule. Albumin and other plasma proteins entering the tubular space trigger an inflammatory response in the tubular cells, activating NF-kappa B pathways, releasing cytokines, recruiting inflammatory cells, that drives interstitial fibrosis, the scarring of the kidney tissue that is the final common path of progressive CKD. The smoke is not just an alarm, the smoke itself damages the walls it passes through. This is why albuminuria is both the earliest detectable marker and an independent driver of faster decline. The more albumin crossing, the greater the inflammatory burden in the tubules. Higher uACR predicts faster eGFR decline, not as a coincidence, but as a mechanism. Reducing albuminuria through blood pressure control, through RAAS blocking medications, through sodium restriction, through appropriate kidney protective therapies is not just quieting the alarm, it is reducing ongoing harm. That intervention conversation is for you and your kidney team, but understanding the mechanism is what makes the conversation possible. Now, why does this work differently at the age and stage that most viewers here are managing? 2 reasons. The first is nephron reserve. Younger, healthier kidneys have sufficient nephron mass that early filter damage can be substantially compensated. Surviving nephrons cover for damaged ones, and the eGFR may stay deceptively stable for years even as individual filter units are failing. In a kidney already at stage 3, already operating at roughly 30 to 59% of expected capacity, there is less reserve to compensate. The remaining nephrons are already under additional load. Filter damage that might have been invisible at an earlier stage becomes a more meaningful fraction of what's left. And second, the conditions that drive filter damage, sustained hypertension and blood sugar effects, accumulate over decades. By the time you are 60 or older, those exposures have had years to act on the basement membrane, the podocytes, the endothelium. The filter is not failing suddenly. It has been changing gradually. The uACR is often the first measurement that reflects how much gradual change has already happened. This is not a reason to catastrophize. It is a reason to have the number. A uACR in a 30 to 300 milligrams per gram, does not mean a fixed future. It means a coordinate. It means a more complete picture. It means a conversation at your next appointment that is more precise than the one that happened without it. Go pull your last labs if you haven't already. Find the eGFR line. If you see a uACR result, write down the number. If you don't see one, write down "not on the panel." That is your starting line. Hold it. The next segment is about why the test wasn't on the panel, and why the answer to that question is one of the most important things you can understand about how medicine moves information from a research finding to a routine order. You now understand the mechanism. You know what the uACR measures and why it catches filter damage before the eGFR moves. You know what happened to Claire's picture once the test was added. A different risk cell, a different clinical weight, a more complete map. The question that follows is the one that surfaces in almost every conversation about this topic. If the mechanism is this clear, if the guideline mandate has existed since 2012, if the test is inexpensive and widely available, why hasn't your own kidney doctor mentioned it? Why wasn't it on your last panel? The answer is not what you expect. It is not negligence. It is not indifference. And it is genuinely not a conspiracy of any kind. The answer is a structural problem. A gap between where the research lives and where the routine order set stops. And understanding it precisely is the thing that turns you from a passive recipient of whatever panel gets printed into someone who knows exactly how to close the gap yourself. Here is the structural truth. The KDIGO guideline, requiring both eGFR and uACR for complete CKD staging, has been in place in various iterations since its original framework in 2012. The 2024 update, published by Dr. Levin and colleagues in Kidney International, reinforces it explicitly. Annual monitoring of CKD requires both measurements, and a doubling of uACR on a subsequent test exceeds expected laboratory variability and warrants evaluation. The guideline is unambiguous. The research behind it is not new. The test itself, a urine albumin-to-creatinine ratio run on a single morning urine sample, costs, in most U.S. laboratory settings, somewhere between $8 and $15. It is fully covered under Medicare Part B for patients with diabetes, hypertension, or CKD risk factors, which describes a substantial fraction of the audience watching this right now. The barriers to ordering it are not financial and not evidentiary. The barrier is a workflow problem. Most electronic health record systems used in primary care carry a default metabolic panel, a set of tests that populates automatically when a clinician orders routine labs. That default panel was built in most institutions before the uACR became a required element of CKD staging under the current guideline. Updating a default panel is not a decision a single clinician makes unilaterally. It requires institutional review, IT involvement, order set governance committees, and approval processes that move on timelines measured in months or years, not in the weeks that follow a new guideline publication. A primary care physician running a 15-minute visit, seeing a metabolic panel already open on the screen, has a cognitive environment in which the uACR simply does not appear, not because they have forgotten it, but because the system has not placed it in front of them. The prompt is absent. And in a 15-minute visit covering medications, blood pressure, current symptoms, refill requests, and whatever else is on the patient's list, the absent prompt does not get added. This is not negligence, let that be clear. The physician who reviewed Claire's creatinine and eGFR noted they were consistent with prior results and moved on to the next item on the agenda was doing exactly what a well-trained clinician does inside a system built for throughput. The KDIGO guideline lag, The gap between publication of a requirement and adoption into institutional workflow runs on average somewhere between 13 and 17 years for clinical practice guidelines to fully penetrate routine primary care in the United States. That figure is not specific to nephrology. It is a structural feature of how medicine moves evidence from a research finding to a bedside habit. The guideline moved in 2012. The average primary care visit has not fully caught up. That is the lag. It is built into the architecture of how medicine functions, not into the character of the physicians operating within it. The same structural gap applies at the level of nephrology referral. Many viewers managing kidney numbers in stage 3 are seeing a primary care physician for kidney monitoring, not a nephrologist, because the wait time for a nephrology appointment in a significant fraction of U.S. geographic areas runs to 3, 4, or 6 months. KDIGO 2024 provides referral thresholds, circumstances under which nephrology involvement is indicated, but the referral still depends on the primary care physician recognizing those thresholds and acting on them, and on the patient being able to access the appointment within a clinically useful time frame. These are system constraints. They are not personal failures. Understanding them as structural lets you do the only thing that actually changes your picture. You become the person who brings the information into the room. That is the close of this segment, and it is also the pivot. The guideline exists. The test exists. The mechanism is now sitting in your understanding in a way it wasn't an hour ago. The system hasn't placed the test in front of your doctor automatically, but you can place it there. And the way you place it there, the specific words, the specific documentation request, the specific follow-up, is what the next part of this hour is about. Now you understand why the gap persists. The question is what you do with it, and the answer is a very specific conversation that starts with one sentence. You do not need to be confrontational to be effective at your next appointment. You do not need to arrive with a stack of printed papers or challenge your doctor or signal in any way that you have concluded they missed something. What you need is one sentence that opens a door, delivered calmly, with the specific number attached, in a way that makes it easy for your doctor to say yes and difficult for the conversation to move on without an answer. Before you say anything, know what you are asking for. The test is called the Urine Albumin-to-Creatinine Ratio. You may also see it listed as the ACR, the Urine ACR, the Microalbumin-to-Creatinine Ratio, or sometimes just the albumin-to-creatinine ratio. Some laboratories list it separately from a standard urinalysis. It is not the same test as the urine dipstick that gets dipped in a cup and read in the office. That test is a screening tool for large amounts of protein. It is not sensitive enough to detect the range that defines A2 albuminuria. The uACR requires a separate urine sample, typically collected first thing in the morning to avoid the variation that physical activity introduces, and sent to a laboratory. That is the test you are asking for. Now, check your last panel one more time. Is there a uACR or ACR result anywhere on it? If yes, write down the number and the date. If it is below 30 milligrams per gram, that is A1. Normal to mildly increased, good news, worth repeating annually. If it is between 30 and 300, that is A2. Moderately increased, the same category Claire's result fell into, and the category that changes your risk classification on the KDIGO heat map when it is combined with an eGFR in the stage 3 range. If it is above 300, that is A3, severely increased, and that number warrants prompt conversation with your kidney team about where your management currently stands. If there is no uACR on your panel, that is the gap this appointment conversation closes. The sentence is this: I read that the current kidney guideline recommends checking both my eGFR and a urine albumin-to-creatinine ratio annually. Has that been ordered recently? And if not, could we add it today? That is the whole sentence. It does 3 things simultaneously. It references a guideline, which names the KDIGO mandate without requiring you to recite it in full, and which signals that this is not a personal opinion but an institutional standard. It asks whether the test has been done recently, which opens the door to the possibility that it has, and that the result simply didn't reach you. Your doctor may say yes and pull the number up immediately, and that is a useful outcome. And it makes the request in the form of a question. Could we add it today? which is easy to say yes to, and which does not imply criticism of prior management. Your doctor's response will fall into one of three categories, and you need a path through each. The first, your doctor says yes, orders it at the visit, and it will come back through the lab portal in the next few days. This is the best outcome. Before you leave, confirm what the normal range is and what the result means at your specific eGFR. Ask, if the result comes back elevated, what would we do differently, and how quickly would we act on it? That question is not anxiety. It is forward planning, and it makes the result actionable rather than just informational. The second, your doctor says the test has been done. They pull up the result. At that point, ask for the number and ask which A category it places you in, A1, A2, or a 3. Then ask, given my current eGFR and this uACR result, what cell does that put me in on the KDIGO risk map? Many primary care physicians are not accustomed to presenting results through the two-axis heat map framing. You are not correcting them, you are asking them to look at two numbers together in a specific framework. That framing is the one the current guideline uses to assign monitoring frequency and progression risk. You have a right to know where you sit on it. The third, your doctor declines to order it or explains that in their assessment it is not indicated at this time. That is a legitimate clinical judgment, and it is not your place to argue with it in the exam room. The appropriate response is one question. Would you be comfortable noting in my chart that I asked about the urine albumin-to-creatinine ratio today, whether it had been ordered and what the decision was, so it's part of my longitudinal record? That is it. No argument, no pressure, just the documentation request. The reason the documentation request matters is this. The doctor who sees you can only protect a result they know is yours to protect. If the question is in your chart, if the date, the request, and the decision are recorded, that information travels with you. The next clinician who opens your chart, whether it is a specialist, a covering physician, or your doctor's colleague, sees that the question was raised and answered. The longitudinal record is your protection in a system that does not automatically carry clinical conversations forward. The compliance line belongs here, stated plainly. Do not stop any kidney medication on the basis of anything in this video. Do not skip a dose. Do not change your treatment plan. The purpose of this conversation is a more complete lab picture, not a different treatment decision made in the parking lot. The treatment decisions that follow from a uACR result are your kidney team's job, not yours. Your job is to make sure the result exists. One more question worth asking at your appointment, and it follows naturally from the uACR result, if it comes back elevated. KDIGO 2024 identifies specific circumstances, including an eGFR in the stage 3 range combined with A2 or A3 albuminuria, as appropriate thresholds for nephrology referral or co-management. If your result falls into that range, you can ask, given my eGFR and this uACR result, does the current CKD guidelines suggest nephrology involvement at this stage? You are not demanding a referral. You are asking whether the guideline criteria are met. The answer may be yes, it may be not yet. It may be that you are already at that threshold. But the question places the referral criteria in the room. And in a system where referrals often happen after the threshold is passed rather than at it, placing the criteria in the room is meaningful. The keystone request, the one that belongs in your chart regardless of every other outcome, is this. Would you be comfortable noting in my chart that I asked about the urine albumin-to-creatinine ratio, whether it has been ordered recently, what the result was, or what the decision about ordering was, and where my current eGFR and uACR together place me on the KDIGO risk map, so this becomes part of my longitudinal kidney record? Write that down. Take it with you. The exact words matter less than the three elements. The test was asked about, the result or decision was noted, and the two-axis staging was addressed. Those three elements in your chart are the difference between a conversation that evaporated and one that travels. You have the research, the mechanism, the before and the after, the sentence, and the documentation request. But there is one more thing. The thing that makes all of this work, not just at this appointment, but at every appointment for the rest of your life. Sit back for a moment. Picture two futures from this point. In the first, you go to your next appointment the way you have gone to the appointments before this. The labs are run, the metabolic panel comes back, the eGFR is noted and is stable or close to it. The creatinine is within range. The visit moves through its agenda. You leave with a refill and a follow-up date. And the uACRs, the smoke alarm, is not on the panel. Not because it was considered and declined. Because the prompt wasn't there, the system didn't generate it, and the conversation didn't open. The filter phrase. The signal sits in the urine. The eGFR, measuring the functional output, holds for another year or 2 or 3, and then it moves. And by the time it moves, the structural damage is years old. In the second, you walk into your next appointment with one sentence prepared. You say it calmly with the guideline reference attached. The test gets ordered. The result comes back, a 1, a 2, or a 3. Either way, you have a number. You know which cell you are in on the risk map. You know whether your monitoring frequency matches the guideline recommendation for that cell. If the result is A1, you leave with the reassurance that your smoke alarm is quiet. If it is A2 or A3, you leave with a coordinate, a specific, actionable data point that goes into your chart, that travels with you, that makes every subsequent conversation more precise. You are not more frightened. You are more located. You know where you are. And then at the dinner table 2 weeks later, or on a call with a sibling, or sitting next to someone in a waiting room who mentions that their creatinine came back a little high and their doctor said it was fine, you know what to say. You know that the blood work looked fine and the smoke alarm was checked are 2 different statements. You know that one number tells you the functional output and another tells you the structural state of the filter, and that the one most people have never had is the earlier one. You know, the sentence that gets it ordered. You hand it over, not as a lecture, as something you found that helped you, that might help them. That is the identity the person who watched this hour builds. The person who reads what the guideline requires before the visit. Who walks in with one good question and the reference that backs it. Who, when the result comes back, knows which of the 3A categories it falls in and what that means combined with their G stage. Who keeps both numbers, the functional readout and the structural readout, in their own records, updated, dated, portable. Who does not wait for the system to generate the complete picture, because they now understand that the system, as currently designed, was not built to generate it automatically. That skill is not specific to the uACR. It is a method. There are 2 axes of information in every complete kidney staging, the functional axis and the structural axis. Once you know they exist as separate measurements, you will notice when only one of them is present on a panel. You will notice when a result is described as normal, without specifying which axis was checked. You will know the question to ask. And that question, asked calmly with the guideline framing, is the portable tool that makes every future appointment more complete than the ones that came before. There are 5 questions that come up consistently when people search for information about the uACR, and they deserve direct answers. The first, how accurate is the uACR? Can one result be trusted? A single uACR result carries meaningful clinical information, but it also has variability. Physical activity, recent illness, fever, urinary tract infection, and the time of day the sample is collected can all affect the result. That is why KDIGO 2024 specifies that a doubling of the uACR on a repeat test, above and beyond what laboratory variability alone would predict, exceeds the threshold of coincidence and warrants clinical evaluation. A single elevated result is a reason to repeat, not a verdict. A morning sample collected before significant exertion gives the most stable reading. If your result is elevated, ask your doctor when to recheck, typically within 3 months, to confirm the finding before major clinical decisions are made on the basis of it. The second, my dipstick urine test was negative. Doesn't that mean my protein is fine? The urine dipstick is a screening tool calibrated to detect large amounts of protein, roughly above 300 milligrams per gram, which is the A3 threshold. A dipstick that reads negative for protein is entirely consistent with a uACR in A2, between 30 and 300 milligrams per gram, because the dipstick is not sensitive enough to detect protein at that level. A negative dipstick does not rule out A2 albuminuria. It never has. The 2 tests are not interchangeable. The dipstick catches fires. The uACR catches smoke. The third, what if my eGFR is above 60? Do I still need the uACR? Yes. The ONDAAS study, published in Clinical Kidney Journal in May 2025, found that in participants with an eGFR above 60, blood work that would conventionally read as within normal range for kidney function, the uACR still identified kidney disease in more than 1 in 10. An eGFR above 60 means the functional output is currently within a range the guideline does not classify as stage 3 or worse. It does not mean the structural damage signal is absent. The two measurements are on different clocks. The uACR is the earlier clock. One quick reminder before we continue. Do not stop or change any kidney medication on the basis of anything in this video. What we are doing is building toward a better conversation at your next appointment, nothing more. The fourth, I've had kidney disease for years. Why am I only hearing about the uACR now? Because the uACR has been in the guidelines since 2012, but the gap between guideline publication and routine primary care workflow adoption runs, by the evidence, more than a decade on average. The test is not new. The mandate is not new. The gap between what the guideline requires and what the default lab order set generates is the structural problem this video is about. You are hearing about it now because you searched for it or because something brought you here. That is not a reflection on the years before. It is a starting line. The fifth, what's the angle here? No, why is Dr. Elizabeth Blackwell making this video? Because the uACR is the most consistently under-ordered test in routine kidney management for the population this channel serves, adults 60 and older managing kidney numbers in stage 3 or at its boundary, and because the research published in 2025 put a number on a gap that had been described qualitatively for years. More than 1 in 10 people with a normal eGFR carrying undetected kidney disease in a primary care population is not an abstract statistic. It is a proportion that maps onto the audience watching this. The mechanism is real, the guideline is clear, and the test is accessible. If what you learn here leads to one conversation that results in one ordered uACR, that reveals a result that changes one treatment plan, that is the purpose. Nothing is being sold. No protocol, no supplement, no program. The test is ordered by your doctor, covered by your insurance, and the result belongs to you. There is a wider pattern here that goes beyond the uACR specifically, and it is worth naming because it is the pattern that makes you better at every kidney appointment you will ever have, not just the next one. CKD has two parallel monitoring systems. The functional system measures what your kidneys are still doing. The eGFR, the creatinine, the cystatin C when indicated. These are readouts of output. They tell you how much filtering capacity remains. The structural system measures what is happening to the infrastructure of the filters themselves. The uACR, the urine protein-to-creatinine ratio, markers of tubular stress. These are readouts of damage. They tell you what direction the output is likely to move and at what pace. Most routine panels cover the functional system by default. The structural system, the earlier system, the one that moves first, requires a separate order in most clinical workflows. The skill this video has handed you is the habit of checking whether both systems are represented on your panel every time you get labs. Not just eGFR, not just creatinine. The functional readout and the structural readout together in the same result set with a date attached. That is the complete picture. That is what the guideline requires. And it is now something you know to ask for. The same structural pattern, one monitoring system defaulting to routine, the other requiring a specific request, applies to other numbers across the panel. Cystatin C, which confirms eGFR when creatinine may be misleading because of low muscle mass or dietary variation, is rarely ordered without a specific request. The eGFR slope, the rate of change across 3 or more readings over time, requires someone to do the arithmetic rather than read a single number. These are not exotic or experimental measurements. They are the measurements the current evidence supports as necessary for a complete picture. Some of them will be on your panel already. Some will not. Now you know the question to ask about all of them, because the question is always the same. Is the system generating the complete picture automatically, or does someone need to bring the missing piece into the room? You are now the person who brings it. You didn't get here by being careless with your health. You got here by paying attention to the numbers you were given. Now you know there is one more number. and it was always yours to ask for. Before your next appointment, write down two things: your most recent eGFR and whether a uACR result appears anywhere on your last kidney panel. Those two pieces of information together are what you bring into the room. The sentence is ready. The documentation request is ready. What the result says next is the beginning of a more complete picture, one that the guideline has required for over a decade, and that now belongs to you. If someone in your life is managing their kidney numbers, a partner, a sibling, an adult child who came home with a creatinine result and was told it was fine, share this with them, not as a warning, as a question they now have the words to ask. If your next question is what your uACR number actually means and what the one move is that can bring it down, that video is linked below.